Okay, well, hello everyone and welcome to the 14th session of the European Journal of Cardiovascular Nursing Journal Club. My name is Robyn Peters and I'm going to be the moderator of this session. I'm a nurse practitioner in cardiology at the Princess Alexandra Hospital in Brisbane, Australia. I'm also an adjunct senior lecturer at the School of Nursing, Midwifery and Social Work at the University of Queensland. Today, I'm pleased to be joined by my colleague, Dr. Mary Boyde, who's a nurse researcher at the Princess Alexandra Hospital Cardiology Department and also an adjunct senior lecturer with the School of Nursing, Midwifery and Social Work at the University of Queensland. Mary is the lead author of Self-Care Educational Intervention to Reduce Hospitalisations in Heart Failure, a randomised controlled trial, which was published in the February 2018 issue of the European Journal of Cardiovascular Nursing. Welcome, Mary. I'd like to begin with asking you to give a short introduction to the paper, please.
Thanks, Robyn. Well, firstly, I'd like to thank Professor Yasma and the European Journal of Cardiovascular Nursing for this opportunity to present our paper at the E-Journal Club. It's a great privilege for us. I'll just start with a very brief introduction about myself and my research. So my research is mainly focused on education for patients. My clinical background is in cardiac nursing, and my research has also continued with a focus in this clinical specialty. My earlier work at the beginning of my PhD involved assessing heart failure patients' learning needs and investigating how these chronically ill patients wanted to learn and their learning styles. From these studies, we developed learning resources that were multimedia and appropriate for people who had low health literacy. These early investigations formed the evidence for the development of an educational intervention, which was aimed at improving patient outcomes. This intervention with these multimedia resources was pilot tested in a small study, and we had 38 patients that we used for that study. And if you're interested, the results from this study were also published in the European Journal of Cardiovascular Nursing in 2012. And so after that study, we were lucky enough to get a very small grant from the Princess Alexandra Hospital Research Foundation, where we work, and we were able to implement the study that we're going to talk about today. Now, just before I start talking about the study, I'd also like to thank Robyn today and tell you a little bit about our history. So we've been working together in cardiology for many years now. We've undertaken a number of research studies, and the topics that we've been involved in include resuscitation, cardiac rehabilitation, heart failure readmissions, patient education, as well as titration of heart failure medications. Right, so now I'm going to go on and talk about the study. I'm going to give a very brief outline of the study, and then we'll go to the questions. So the literature shows us that there are a variety of education interventions that have been implemented to assist patients with heart failure. And it's to help them manage their own health and develop those self-care behaviours that will decrease readmissions. Studies in the past have implemented a variety of educational strategies for these patients. However, sometimes the protocols do not describe education as a specific intervention. Rather, it's provided as an element of their heart failure management. Often only a brief outline of the actual content of the educational intervention is provided, and it's combined with multiple post-discharge follow-up strategies. In addition, the educational theory which supports the intervention is often inadequately described, thus decreasing the ability to reproduce and make generalizations from the results. While the benefits of patient education have been long established, all we've hoped for patient education has not yet been realized. I think inconsistent findings in the effects of education interventions are most likely due to the heterogeneity of these studies, and there's a lack of a clear relationship between education delivery methods and the beneficial patient outcomes that we see. Therefore, taking all this literature into account, we aimed with our study to develop to examine the effectiveness of a multimedia education intervention for patients with heart failure, aiming in reducing unplanned hospital readmissions. So we implemented a randomised controlled trial in our large tertiary referral hospital here in Brisbane in Australia. We recruited 200 patients. This study recruited eligible patients, and these were the patients who were diagnosed with heart failure, who were referred to our heart failure management program. And the inclusion criteria that we included were those people who'd been accepted into the heart failure management program. They were adults aged 18 years and over, And we excluded people who were unable to read and write English, those people who had a visual or hearing impairment which would limit their ability to see a DVD, people with a significant cognitive impairment, those who were living in residential aged care, those that were being considered for a heart transplantation or an artificial heart device, and also those who were diagnosed with a terminal malignancy. The eligible patients who we recruited were randomly allocated 1-to-1, either to usual education or to the multimedia education intervention. This intervention that we had developed and then implemented began with an individual needs assessment to develop an educational plan for the patient. The educational intervention included viewing the DVD and a verbal discussion with a healthcare professional, and it was supported by a written manual, and at the end of the session we had a teach-back strategy. As I indicated earlier, this intervention was developed from our previous research and had been successfully piloted before we did the RCT. The theoretical framework was the Principles of Adult Learning by Knowles, and many of you will be quite familiar with that, so I'm not going to dwell on that. The primary outcome of our study was all-cause unplanned readmissions at 28 days, 3 months, and 12 months post-recruitment. And the secondary outcomes were changes in knowledge and self-care behaviours at 3 months and 12 months. So from our results, at 12 months, we had complete data set on 171 patients. There were 24 patients who had an unplanned hospital readmission in the intervention group, compared to 44 participants in the control group. So that was statistically significant with a p-value of 0.005. The self-care education intervention reduced the risk of readmission at 12 months by 30%. And we did also look at the secondary outcomes. And just to briefly mention that for knowledge, there were no significant differences in the knowledge scores between the intervention and control groups at 3 months and 12 months. Within each group, there were statistically significant differences, but between the groups, there wasn't. And it was a similar result for self-care. So analysis at 3 months and 12 months showed no significant difference in the scores for maintenance, management, or confidence between the intervention and control groups. However, within each group, the maintenance scores between baseline 3 months and 12 months did increase significantly. And within each group, the self-care management scores also increased across the 3 time points. Self-care confidence scores across baseline 3 months and 12 months did increase significantly within the intervention group, but not the control group. And there's a question about that later, so I'll discuss that again later. And also just to mention the final part of our results, at 3 months, 79% of the people who had the intervention indicated they had watched the DVD, and 87% said that they were using the manual, the information that they were given at home to help them manage their heart failure. Okay, and so then from those pleasing results, we were able to conclude that our targeted multimedia education intervention was effective in reducing all-cause unplanned readmissions for people with heart failure.
Thank you, Mary. That's a very comprehensive overview of the study. I always think hindsight's 20/20. So if you could look back at the study and have a little think about what it, or if anything, you might have changed, be it with the design or the data that you collect, or the recruitment processes.
Thanks, Robyn. I think looking back, there was lots of things we could think about, and I think one of the critical things was that if we'd had more funding, then we would have been able to collect a more extensive set of data. And some of the things that we could have looked at and collected data on would have included health literacy, depression, quality of life. So I also think that if we'd had some more funding, we could have continued to follow up for 24 months. So we would have got a more extensive range of data, and perhaps we would have seen different results at 24 months. And of course, if I was to run the study again, it would be really great to have a multi-centre study rather than just at one site. I think that would have given us more extensive data as well.
Great, thank you, Mary. So I'd just like to move on to the questions that have been submitted. And firstly, a disclaimer. I'd like to ask for forgiveness for any pronunciation mistakes that I make, and of course the Australian accent, which sometimes I'm told is a little bit difficult to understand. So our first set of questions comes from Dr. Stefan Kubarich from the Heart Center, University of Freiburg, Germany. And the first one is about the introduction of the study. He felt that, so we had said that there were inconsistent findings in the effects of educational interventions, which were most likely due to the lack of clear relationship between education delivery methods and beneficial patient outcomes. This seems to emphasise the importance of the delivery method. However, within the introduction part, no statement could be found how heart failure-specific education interventions are really working regarding preventing rehospitalisation. It's a long way from knowledge gaining to good self-care activities, and there's also studies suggesting a plethora of influencing factors. Clearly, is there a clearly defined and evidence-based theory why educational interventions may prevent rehospitalisation in patients with heart failure?
Well, thank you for this very important question, and it really highlights what the main issue is for us and for all of us. We know that rehospitalisations for heart failure patients are multifactorial and varied. However, we do have evidence from some earlier research by Coling and colleagues that 1 hour of one-to-one education prior to hospital discharge decreases hospitalisations and increases heart failure patients' self-care abilities. There's also a very recent systematic review by Rice supporting the effectiveness of nurse-led one-to-one education on readmission. So our intervention was based on individual assessment of the patient's learning needs prior to delivering the education and then focusing on those self-care abilities. For example, with the DVD that we'd developed and tested and we used in this study, we show a man at home who's got heart failure and he's just been discharged from the hospital, and he implements the self-care that he needs to monitor his symptoms. So it shows him in the morning getting out of bed and going to the scales and weighing himself. And then he realises that he's put on excess weight, and he rings his heart failure nurse to tell her that he's gained more than 2 kilos, and together they discuss how he will manage his increased weight and what's happening to him in his heart failure. I think a focus on how patients will implement the self-care activities into their daily activities increases the uptake of these self-care behaviours, and it's likely contributed to our results in this study. However, I think there is still a lot of research to be done in this field to fully answer your question, and at the moment there's not a clear answer.
Okay, so Dr. Kubarich also asks, do you think that there is a perfect education intervention fitting for all heart failure patients?
Again, this is a really important question, and I can see that you're very interested in this area that we're working in. So I think that for every patient that we see, they have their own learning needs and indeed their own learning style. This can be challenging in a research study because we need to standardise the educational intervention. The way we approached this for our study was to standardise the learning needs assessment and have multimedia resources for every patient in the study. In this way, the nurse delivering the intervention was able to focus on the specific learning needs of that patient while the study was still using a standardised approach, and all the patients received all the resources. At follow-up, nearly all the intervention patients who received the DVD said they'd viewed it again at home. However, the reality is that some patients will prefer a DVD, others will prefer a booklet, some might prefer to use a website, and patients will have different ways of learning. I feel the most important aspect of this intervention and any educational intervention is the assessment of the patient's learning needs before we implement any education.
So in that case, which content should be incorporated in educational interventions in any of those cases?
So I think the key here is that the content needs to reflect the patient's learning needs. That's why it's best to have a range of multimedia resources available, and you will need a specialist healthcare professional or nurse who can adjust the content to that patient's own learning needs. It's often not the content which is critical, I feel, but the delivery strategy, including the use of a teach-back evaluation to assess the patient's understanding of the information and then reteach or go back over information that hasn't been clearly understood.
And I think in your previous work, Mary, you found that it's actually the relationship between the healthcare provider and the patient that also has a great impact on their learning.
Yes, I think so. It is the actual delivery, the person who's delivering it. We've certainly found that many people, when they're in a relationship with someone that they trust to give them valuable information, a nurse, a doctor, a healthcare professional, then they learn more effectively. So I think it's about the delivery and the person who's delivering it, as well as having appropriate resources that suit the way that person wants to learn. Many people do like to see a DVD, but we have come across patients who say that they prefer not to watch. They don't want to watch a DVD. So again, it's about adjusting to suit the needs of the patient rather than one size fits all.
Thank you. So the question about educational intervention being able to prevent rehospitalisation. So statistical procedures of comparing outcomes at different time points has been applied in the study. The used procedures are only reflecting the difference at a specific time point, but does not consider changes over time and the influence of the intervention. Do you think that a mixed ANOVA with repeated measurements, which is able to assess a time intervention effect, would yield different results?
Well, unfortunately, the outcome data in the study did not meet the requirement, the assumption of normally distributed data. So we were unable to use the parametric statistical analysis. So that's why we used the non-parametric tests.
Okay. And then finally from Dr. Koberich, he's asked, were there any missing data and how were they handled?
So at 3 months and 12-month follow-ups, the patients who remained in the study who had not died or withdrawn who we were not able to contact, they all completed the questionnaires. So all of the data from those patients was collected. And the patients who we weren't able to contact, obviously their data was not there for analysis. However, we felt we had good retention. We only had 9 patients who we lost to follow-up who we weren't able to contact over the 12 months. So that was 5 in the intervention group and 4 in the usual care. However, we did have a number of patients who died over the 12-month, so that's why we didn't have as many patients at the end.
Okay, thank you, Mary, and thank you, Dr. Koberich, for your questions. The next set of questions comes from Iona Lakamitu. I'm sorry if I didn't pronounce that correctly, who's a cardiology nurse at the American Medical Center, American Heart Institute in Cyprus. And she asks, what do you think is the reason for the difference between all-cause readmissions and heart failure readmissions on p-values?
I think the difference here is due to the small number of heart failure admissions compared to the all-cause unplanned admissions. So if the study had a much larger sample size, we may have seen a statistically significant difference in the heart failure readmissions. So for example, if we look over the 12-month follow-up time frame for this study, we only had a total of 22 or 13% of our patients who had a heart failure unplanned readmission. So 14 in the control group and 8 in the intervention group. So this may be due to the fact that all of the patients in this study, whether they were in the control or the intervention group, were enrolled in a heart failure management program. And so they were all really getting gold standard treatment. They were all getting education. And I think this is the difference between, that was the only difference between the two groups, where the intervention group were getting additional education. So I think the number of heart failure unplanned readmissions for this cohort of patients, both the control and the intervention group, was very low compared to what we're seeing if we look at the published literature around heart failure readmissions.
Okay, so Iona also asks, is there a possible different educational intervention, example, including social support, that can be done in order to have lower heart failure readmissions and statistically significant results in the two groups?
It's difficult to answer this question. We did not include a psychosocial intervention for our study. However, I think it's something that could be tested in the future. Our focus really was on education, as we feel that education is an important aspect of the nursing role, and even a brief education intervention has the potential to positively impact on patient outcomes. So we just focused really on the education for our study, but certainly I think it is something that it could be done in the future.
So thank you. And Faye, who's a research nurse, was interested to know if the authors feel undertaking a needs assessment implementing an individual 60 to 90-minute discussion and evaluating understanding using teach-back approach could be reproduced outside the clinical trial setting.
Yes, I firmly believe that this can be reproduced at the bedside. This really was the aim of our study, was to get an intervention that could be easily delivered at the bedside in hospital. We implemented this study within the clinical units here at the hospital, and while we did obviously have a dedicated nurse specialist delivering the education intervention for the study, it could be delivered by a specialist trained nurse. All patients enrolled in our heart failure management programs here receive a bedside consultation prior to discharge with a specialist heart failure nurse. So we feel in our study, in our setting, this approach is very feasible. It's a brief intervention and really is a one-on-one consultation at the bedside with appropriately trained nurses.
So Faye also was interested to know if an enhanced knowledge of teaching theoretical frameworks is required.
Well, I like to use the principles of adult learning from Knowles to guide education interventions for adults. I think that healthcare professionals, such as nurses who are teaching patients, do need to understand these principles. However, I feel that these principles would often have been included in undergraduate preparation. So many nurses are familiar with these principles, and we just need to apply them in the healthcare setting. Additionally, I think healthcare professionals, especially nurses, need to have an understanding of health literacy and how this impacts on health. Using a universal precautions approach to teach our patients will improve their ability to understand, to engage, and then incorporate those self-care behaviours that are so important into their everyday health management.
Thank you. And thank you, Faye. Samar Noureddin, who's a professor at the Hariri School of Nursing, Lebanon, her question was in relation to the consort flow diagram. I'm sorry if Samar is, I wasn't sure if it was a man or a woman, so my apologies. And participant numbers throughout the study. Samar asked if the authors could explain the numbers of the study consort flow diagram starting 3 months follow-up. It seems the numbers do not add up.
Thank you for your question regarding the consort flow diagram. So I'll just clarify and take you through the diagram. We recruited 100 patients in each arm of the study. So if we look to the intervention arm first, you will see that at 28 days, 1 patient had withdrawn, 2 patients had died. So that left us with 97 patients. At 3 months, in total, 2 patients had withdrawn from the study, 2 could not be contacted and were lost to follow-up, and 4 patients had died. So that left us with 92 patients out of the 100 that we started with. And at 12 months, in total, 2 patients had withdrawn, 5 had been lost to follow-up, and 10 had deceased. So that left us with 83 of the patients that when we started with 100. And similarly, in the standard care arm, at 28 days, 2 patients had died. So that left us with 98 patients. At 3 months, in total, we had 1 patient who had withdrawn, 2 who we could not contact and were lost to follow-up, and 3 who had died. So we had 94 patients in total. And at 12 months, in total, 1 patient had withdrawn, 4 had now been lost to follow-up, and 7 had deceased. So that left us with 88 patients. So when you look at the consort diagram, just to clarify, the numbers at each follow-up are the total numbers. They're not additional, they're total numbers from the study. So you just take it away from the 100 that we started with.
Okay. Samar also noted that in the readmissions, there was a discrepancy regarding the number of participants at 3 months.
Under readmissions, we had stated that at 28 days, 4 participants had died and 1 had withdrawn, which left 195 patients. And again, you can see that in the consort diagram. At 3 months, in total, 7 had died, 3 had withdrawn, and 4 had been lost to follow-up, leaving us with a total of 186 patients in both arms. At 12 months, 17 participants had died, 3 had withdrawn, and 9 had been lost to follow-up, leaving us with the 171 patients whose data we were able to analyse. So again, just to clarify, the numbers for each follow-up timeframe are the total numbers.
Thank you for clearing that up, Mary. So Samar also would like to know how the authors explain the significant increase in the confidence in the intervention group and not the control group regarding the intervention that was used.
Yes, as I mentioned when I was introducing the study, we did report self-care confidence scores across baseline 3 months and 12 months increased significantly within the intervention group, but not the control group. We're unable to identify the reason for this, but I believe using the multimedia approaches to education, which focused on implementing those self-care behaviours, contributed to improved self-care confidence for those patients who received the education intervention. When we look at the score for self-care maintenance and management, both groups improved their scores, but there was no significant difference between the groups. This may reflect the situation where all patients received education about self-care, whichever arm they were in, and therefore they were able to implement self-care behaviours. However, the group that had the intervention showed improved confidence in their abilities to self-care.
Thank you. So Mara goes on to state that the fact that a specialist heart failure nurse provides education to the control group can explain a lot this non-significant group difference in knowledge and self-care scores. So given that, what would such intervention add to the standard care? What do they recommend so as to strengthen future intervention studies?
Yes, I agree that as all patients receive the education from specialist nurses, and this is a standard care in our heart failure management program, it's difficult for us to show the full impact of education. However, we did show decreased readmissions, and we can be confident that the education strategy, similar to we used, which is based on the needs assessment, using the one-to-one delivery method with TeachBack and using those multimedia resources, has the potential to improve outcomes for patients. For future studies, as I said earlier, a multi-site approach with a larger sample size would yield more evidence for us. And also, we could think about measuring self-care in other ways rather than self-reported measures.
Okay, thank you, Sema, for your questions. Adita Laitolip, who's a PhD student, she asked some questions related to the characteristics that may impact self-care and knowledge and the correlation between improvement in these with readmissions. Adita states that study results are presented as median with IQR for both groups. It would be interesting to look for patient characteristics that have impact for their improvement in knowledge and self-care. As we know from our findings, analysis of the InTouch study data, that greatest improvement of self-care may be achieved in those patients who have low initial self-care level or medium initial self-care level in the absence of depression. Depression has strong impact for patient self-care, but level of depression in this case was not evaluated. And also, it would be interesting to look for correlation between improvement in knowledge and self-care scores with readmission in both patient groups.
Okay, well, thank you for your questions. I think it would be excellent if we could have examined more variables, and certainly depression would be one of the variables that it would be good to examine, and we didn't do that in this study. We did find, however, when we did our pilot study, which, as I mentioned earlier, has been published in this European Journal of Cardiovascular Nursing, that education level and age group were significantly associated with improvement in knowledge scores. So in our pilot study, the patients who were aged 75 years or older and had the lowest education level achieved the largest mean difference between pre and post knowledge scores. Therefore, the education intervention that we piloted was effective in developing knowledge in this older age group. So the older people benefited the most from the education intervention. So we found that very interesting, and we really felt that it demonstrated that it was worth targeting and providing education for older people, because they actually often had the lowest pre-intervention scores, and they had the largest mean difference between pre and post. So education level and age group were, in our pilot study, significantly associated with improvements in knowledge, and that correlates with other published studies as well. So I think there are lots of variables that could be looked at, and maybe in a new study we could certainly try to include more variables, and we are aware that depression would be one of the variables that would be good to look at.
Okay, so thank you, Adita, for those questions. That just about wraps it up for us here tonight. Here, I think it's morning over there. And so I'd like to now draw this e-journal club to a close. Thank you so much, Mary, for your time and sharing your expertise in patient education with us. And if you are interested, the articles that we've spoken about can be accessed through the European Journal of Cardiovascular Nursing. Please access the journal homepage on the Sage Journal platform. If there are any questions that you might have about this session or the paper that we've discussed, please email ejcnclub@sagepub.com. Finally, on behalf of Mary and myself, I'll say farewell from Australia. And I forgot to say good day at the beginning. And thank you for taking the time to forward the questions and watch this session today.
Thank you.
Bye.